Hello, I'm Suresh Gunasekaran, CEO of University of Iowa Hospitals and Clinics and Associate Vice President for UI Healthcare. We are delighted to again be part of the Iowa Ideas Conference. Now in its fourth year, Iowa Ideas provides a unique opportunity to bring together a wide variety of different voices, perspectives, and thoughts to create a better future for us all. 2020 is a year that none of us could have predicted and has given us unprecedented healthcare challenges. In some ways, these challenges have made us better at delivering care, but it has also further highlighted the serious gaps some Iowans face in receiving adequate healthcare services. Let's start the discussions here and follow through to deliver better health for all. Thank you for being a part of this important discussion.
My name is Randy Evans. I'm the moderator for the afternoon. I spent 40 years at the Des Moines Register, and for the last 5, I have been the executive director of an advocacy and education group called the Iowa Freedom of Information Council. Our panelists today, we've got a terrific group for you, so don't be bashful about submitting questions. First, I would like to introduce Doug Ommen, who is the Commissioner of the Iowa Insurance Division. Tricia Neuman is a policy analyst for what is either known as KFF or the Kaiser Family Foundation. We have Casey Ficek, who's the Public Affairs Director for the Iowa Pharmacy Association. And we have Anthony Carroll, the Advocacy Director for AARP of Iowa. The first question, Commissioner, people probably think that Iowa's insurance commissioner has a lot of authority over prescription drug prices in our state. Set us straight. How close to reality or fantasy is that?
First of all, it's great to be with you and have a chance to visit about this. And thank you, Randy, for that question. We at the Iowa Insurance Division, as a state regulator, we are often put forward by our legislature as the line of defense when it comes to prescriptions. The reality, however, is that when we have made efforts to do that, that is to put in place some regulatory authority over prescription pharmaceutical benefit managers, PBMs as they're known, that the problem has been that the PBMs have taken us to court and used offensively the preemption under ERISA. Because PBMs, they serve as both the insurance part of the market as well as the self-funded part of the market, which is controlled by federal law under ERISA. There is an argument to be made that we are preempted from exerting any regulatory oversight. So when that was done a number of years ago now, as I mentioned, we got sued. It's interesting to note, however, that continues to be litigated. Just as recently as last week, a similar effort out of the state of Arkansas went through the 8th Circuit, and based upon what the 8th Circuit had done in our case with Iowa, they had also stricken the law down in Arkansas, but that has been appealed to the Supreme Court, so hopefully we're going to get a better answer. Your question was about fact and fiction, and the problem is that it is a fact that in some jurisdictions across our country, because of different circuit decisions, states do have more authority over the PBM business. But as for here in Iowa, it is really more of a fantasy because of the fact that to date, the courts have not really allowed us to exert much control. Our legislature did last year enact a provision that allows us to gather aggregate information in terms of the way the PBMs administer their business, and based upon that legislation. We are gathering aggregate information about the rebating process, but the reality is over time that may be of some benefit to us as a state as we make policy. But by and large, our efforts to require more transparency, our efforts to require, that is in terms of drug pricing, our efforts to make sure that the behavior of the PBMs does not unfairly compete or discriminate against local pharmacies has been struck down. So to some degree, we're a little bit on standby. I'm very grateful to be on the panel. You know, obviously we continue to give a lot of attention to this. We have supported efforts nationally for Congress to act, but as regulators, we have right now pretty limited powers.
Thank you, Commissioner. Tricia Kaiser is a big name in healthcare in the United States, but clear up the confusion that may be out there about what you and your colleagues at the foundation do and what you don't do.
Okay, sure. Thank you. And thank you for having me. It's really a pleasure to be here. So a lot of people have heard of the word name Kaiser because of Kaiser Permanente or maybe Kaiser Industries, but in particular Kaiser Permanente in terms of healthcare. We are not at all affiliated with Kaiser Permanente, and I feel like I have to say that when I speak on panels because people come up and start complaining about their formulary, or they tell me about their health problems. And as much as I care about everybody's health problems, it's not really what I do. The Kaiser Family Foundation, or KFF, is an independent, nonpartisan, nonprofit organization that focuses on healthcare issues, health policy issues. We do policy analysis, we do polling, and we also have a sort of a separate entity that you may have heard of called KHN, which is our news service, which is also independent. So I'm in the policy shop, and my work has focused on healthcare for older adults, but also we've been spending a lot of time tracking what's going on in Congress and with the administration on prescription drug issues, because it is such a big deal. And our polling team has been looking at how the public feels about drug prices. And as I think everybody on this call knows, it's really a big deal. People are very concerned. 29% of people said that they didn't take their medicines as prescribed because of a cost problem. It's a pocketbook issue. It's one that's not gone away. And while the Congress has spent a fair amount of time this year working on the issue, the House passed a bill. Senator Grassley and Senator Wyden moved a proposal, at least out of committee, and the administration's talked a lot about it. But with all the talk, there hasn't really been a lot of action. And so I'm happy to be here to talk about what more can be done, because I think this is an issue that people really care about.
Thank you, Trish. Anthony, we know AARP is the giant organization of seniors. What are you hearing from your members about prescription drug costs?
Yeah, well, what I'm hearing from them is simple message, but in so many voices, in so many ways. Americans shouldn't have to pay the highest drug prices in the world for the medicines they need. And they understand this in intuitive ways. It's really interesting. We organized this panel. Literally a year ago, this time, I flew out to Washington, D.C. With the AARP member, an active volunteer from Sioux City, Iowa, Doug Neuman. It was actually his first trip to Washington, D.C., literally a year ago today. And then literally a year ago tomorrow, on October 16th, Doug spent his day meeting with our congressional delegation. You can actually, for those of you who want to multitask, go to your phones right now and you can look at Senator Grassley's Instagram or Twitter, either one, for October 16th, 2019. You'll see a picture of Doug Neuman standing right next to Senator Grassley. He was there as one of the thousands, and I mean literally thousands of just Iowans, not to mention Americans, who have shared their story. And Doug did so again, keep in mind his first trip to DC, in a very public way. Because not only did Doug meet with our congressional delegation, and Senator Grassley will come back to that. His key role, his pivotal role in this, to try to get a bill through Senate and Congress. Doug was there because he also was one of 2 Americans who shared his story at a press conference with the House, the Speaker. You can actually go back and look at that a year ago on the 16th. And here's Doug's story, and I'll just share it. I have so many stories I can share, but Doug, sadly, is typical. Here's what Doug said at his press conference. My name is Doug Neuman. I was born and raised in Sioux City, Iowa. When I was 15, I was in a hunting accident, and the bullet went through my neck, took a kidney out, and out my back. 40 years ago, we're great with 1 kidney, but in 2011, the kidney was failing. I was fortunate enough to receive a kidney transplant. Right now, I'm on 32 pills a day. I'm on them for the rest of my life, and if you read the side effects, you wouldn't take any of them. I can't deliver that as well as Doug did, so like any of this. If I don't get the diabetes pills, my blood pressure pills, and anti-rejection drugs, I'm a dead man. Since 2012, my medical expenses for prescriptions increased tremendously, as high as $500 a month. My expenses for prescriptions are so high, I'm going to have to move into where I work and take another part-time job. And keep in mind, Doug's in Medicare. I was unable to do this work to pay for those prescriptions. If I wasn't able to do that, I might as well start planning a funeral. On behalf of millions of others like me, I'm here today asking Congress to take action now to lower prescription drugs prices. I've seen too many people deciding between filling their prescription drugs or buying groceries. This cannot continue. There's no reason why Americans should continue to pay the highest drug price in the world. And I'll briefly add, Doug is one of many stories. In 2019, our state fair booth was devoted to gathering prescription drug stories. And I'm just celebrated my 15 years with AARP Iowa. Proud to work here. We've had lots of state fair booths, sometimes on issues. Sometimes, you know, I wish they were engaged at the level they were engaged on the prescription drug stories. We gathered over thousands of stories. That's also something you can see on Senator Grassley's Instagram. Shared those with not just Senator Grassley, but other members of our delegation. And again, I won't, go on and on with all the stories. I feel like part of me wants to do that because they're as important as me. It's not about me, but I can tell you people are fed up, and certainly COVID has affected things, but we have had teletown halls that we posted with a number of our Iowa congressional delegation, as well as attended. And I can tell you, literally has produced all those or attended all those without failure. Someone gets on and shares one of the most heartbreaking stories, not COVID related, but COVID adjacent, certainly connected, a heartbreaking prescription drug story. So we think that there's momentum. I know Randy and others who want to explore that we want to revisit getting a bill passed in Congress, and then happy to also talk about some of the actions taken by Iowa and perhaps other states to really lower prescription drug costs.
Thank you, Anthony. Casey, Iowa's pharmacies deal face-to-face with the consumers and are on the receiving end of lots of feedback from those people when they come in to pick up their medications. Your members are caught in the middle on this issue. What are your members telling you that they're hearing from consumers, and what's the association hearing from those pharmacists themselves?
Yeah, thank you, Randy. I think you hit it spot on, and that was something that I was going to highlight no matter if you asked that question or not, but it really is a similar story to Anthony in that our pharmacists deal firsthand with these stories of the same people that Anthony is talking about, and they feel powerless in their ability to try to provide solutions to these patients who can't afford their medications anymore. And all of those, the list of stories that Anthony had mentioned, and we've talked about this before, there's more than we know of, and this problem has only gotten worse. And I think the frustration grows with so far the inability to find sort of that silver bullet solution. And there's not going to be a silver bullet solution. There's a lot of actors at play, and Commissioner Ommen mentioned pharmacy benefit managers. Obviously, the manufacturers have a part to play in this as well. And so the frustration comes from our members sort of twofold. First, that they can't help their patients find any options that would help them be able to afford their medications. And then second, that as they deal with PBMs, like Commissioner Ommen mentioned, they're not receiving sort of any help on the back end either. And so just for the audience to be aware of, PBMs or pharmacy benefit managers, they are primarily responsible for managing a health plan's prescription benefits. So, you talk about pharmacists kind of being in the middle of the patient. Well, the PBM is in the middle of the patient, the pharmacist, and then in between the pharmacist and the health plan. And in that role, they started as claims processors, but have really grown into behemoth corporations that handle the entire prescription health benefits. So you talk about developing and maintaining formularies, contracting with pharmacies. A big part when we talk about looking at how this might affect drug prices is negotiating discounts and rebates with drug manufacturers. And then they also deal with processing and paying for those prescription drug claims, so setting the reimbursement rates for pharmacies. And in that role, like I mentioned before, there's certainly a lot of actors, and I think it's important that we shine some light on sort of the behemoth middlemen that have a role in driving up these prices as well. I know the manufacturers get a lot of attention, and like I said, there's certainly a role for them when we examine solutions to try to find lower prices. But at least what I hear from our members when, Randy, to get back to your question, is that there's a lot of frustration, and this has gone on for years, with PBMs and sort of the unnoticed role that they've had in driving up prescription drug prices. And so we've had, it's interesting, we talk about, Anthony, you talk about flying out to DC last year, and it felt like we were on the precipice of finally achieving something and getting a bill through. And I need to give credit to Senator Grassley, who has been out front on this issue, both in looking at finding solutions with the manufacturers and then also for the PBMs. And prior to COVID-19, it finally felt like this was going to be the time that we were able to pass something comprehensive and meaningful. And, like everything in life, things got interesting in March, and everyone's focus changed to sort of getting by and getting through the day-to-day. And while I still think there is momentum, it's definitely great to be on a panel like this to be able to shine some attention on what was a huge issue prior to COVID-19.
Well, I think just to follow up on one of your points there, Casey, is I think probably the audience may not be aware of, as the pharmacy benefit manager's role has grown in the healthcare. One of the effects of that has been the reduction in the number of pharmacies that people are working with. The local pharmacy is, there aren't as many of them. They're being squeezed out. Talk about that.
Yeah, so this, when you look at sort of the direct impact of how PBMs affect drug prices, and then you look at the indirect impacts on patients, one of the sort of the drum I always beat is just the lack of access that we've been heading towards as community pharmacies, and not just community pharmacies, but even some of your larger chains have been sort of driven to really, really tight margins, and in a lot of communities driven out of communities when you look at independent pharmacies. And the role that PBMs play is probably one of the most crucial points in seeing that reduction in services and access. Like I mentioned before, there's really, I think, a misunderstanding of the role that they play, but there's 3 PBMs that control roughly 76% of the market, and that number fluctuates. They cover, and these numbers are constantly changing, but about 238 million lives in the United States. PBMs have revenues that are in the billions, close to hundreds of billions every year. I pulled these numbers just because I think they're astounding. But so CVS Caremark is one of the largest PBMs in the country. They acquired Aetna for $69 billion a few years back. So someone who has that kind of ability and purchasing power obviously has a lot of cash to work with, but also a lot of influence. Cigna acquired Express Scripts, which is another PBM, for $67 billion a few years back. Those are just massive numbers. And what PBMs assert is that they are passing along and negotiating savings for their consumers, but they have no fiduciary duties to the plans or the patients that they work with, and utilize a lot of tactics that get my members fired up. Some tactics that include what's called spread pricing. So charging the plan one thing and then reimbursing pharmacies another, and holding on to a massive amount of spread in the middle. There was an example in Iowa not too long ago that the House Government Oversight Committee held hearings on, and that was down in Wapello County. And what a community pharmacist was going through sort of his numbers, and he provided prescription drug services and to the county jail, and he looked at what he was being reimbursed and then what the jail was paying, and found that on some prescriptions, the PBM was pocketing close to $2,000 on a single prescription. And so the assertion that we always hold is that while PBMs say they're saving consumers money, they're really found a great cash cow that they've managed to exploit and aren't passing along those savings to consumers. But to get, sorry, I can talk on this for days, because it really is the one thing that gets pharmacists fired up. But just to get back to your original question, as far as what that impact has when you lose a community pharmacy, or, oftentimes small towns have an independent pharmacy that your physician clinic might rely on. Dental clinics usually go hand in hand, and as PBMs have consistently squeezed pharmacies to smaller and smaller margins and forced them out, those patients lose access to one of the most accessible healthcare providers. And Anthony, you mentioned, I believe, the story of Doug. He was on 31 medications. Well, one of the things that pharmacists pride themselves on is being able to provide information that allows patients to manage those medications and provide the most effective and optimized outcomes, especially for those patients that are on numerous medications. And when you force out your community pharmacy, and those patients might have to turn to mail order pharmacies that are typically owned by PBMs and don't provide the same level of service and accessibility that your community pharmacy will.
Thank you, Casey. Tricia, I'd like to put you on the spot and ask, are we kidding ourselves when we talk about achieving price stability for pharmaceuticals? Are we kidding ourselves that we're going to see prices come down at the retail level?
Well, it depends on whether you ask me on an optimistic day or not. This time last year, I was an optimist. I really saw the seeds of compromise in federal legislation. For example, there was a general agreement. Sorry, practical issue. Sorry about that. There was general agreement. There was a provision in the administration's budget, in the House bill, and in the Senate bill to provide a cap on out-of-pocket spending for people on Medicare Part D plans. That's enormously helpful. That would have helped over 1 million people who have spending, really high spending, straight away. It would have said, once your spending exceeds a certain level, and they would have had to negotiate because they had different levels, then Medicare essentially would pick up the cost primarily. That would have been hugely helpful, and they all had a similar provision. There is also agreement on the concept of limiting price increases to inflation. That was in the Grassley-Wyden bill. There was something like that in the administration's proposal and something in the House bill. That's a pretty big thing to agree on. That would make a difference, because we've all heard about crazy high price increases. Beyond that, there were some real differences. I'm not going to kid you. I mean, the House had huge savings that would have been attributable to allowing the government to negotiate drug prices. And that would have been $500 billion in savings. So that would have been a big source of relief to not only people on Medicare, but to other consumers, because it's extended to private insurance. That was not in the Senate bill, and that would have been pretty contentious. But there is pressure. I think there's ongoing interest, and I think there are definitely common elements that I could see happening, certainly not before the end of this Congress, but it's entirely possible that the Congress could reconvene with whoever's in the majority in the House and the Senate, and with whoever's in the White House, to try to find an agreement on this issue, because it's an issue that really affects people, upsets constituents. States can't do it on their own, and there's a real demand for progress. Now, that is my most optimistic way of talking about this. I can also talk about huge forces. You've just heard about the power of the pharmacy benefit manager in industry. They are hugely powerful and large, and we haven't really talked about the power of the pharmaceutical industry itself, who has historically opposed many of these provisions that we've talked about. They might go for the cap on out-of-pocket spending, but anything that imposes real price constraints on pharmaceuticals would be something that I would imagine they would fight pretty aggressively to stop in its tracks. So we'll see. I mean, I do think there's a possibility. I think there are a lot of other issues that are awaiting this next Congress. So with COVID, prescription drugs has kind of fallen down from the top of the list. People are very, very concerned about the effects of COVID, the health effects. They're worried about a vaccine. They're worried about the economic implications. And so I think prescription drugs is not quite the top issue that it was. It's probably also right behind the ACA and issues around pre-existing conditions. But once you kind of roll down a layer or two, people are worried about this. And I think there's real interest in trying to do something about it.
So
how's that for optimism for you today?
Yeah, that'll serve in this this particular week. So if I could follow up, where should the blame lie that things have gotten kind of sidetracked, I would say? Is it a convergence of factors? Is it, is it politics? Is it the consumers are wanting too much? Is it the benefit managers and the manufacturers? What's the, where's the roadblock really exist?
Well, we never got to the point of seeing what real negotiations look like. We never got to a conference. Usually when there's a House bill, there's a Senate bill, and there's a conference. That's like the old way of making law, and then the administration comes in and weighs in. They didn't really get that far. The Senate, unfortunately, never voted on the Grassley-Wyden proposals. So why that didn't happen, I'm not so sure. This is a very controversial topic. There's a lot of money at stake. There's a lot of profit in some of these entities that we've been talking about, and there's a lot of revenue to be lost by these companies. And I think that had to have been, if not on the surface, just closely underneath it. And we didn't really get a chance to see the politics play out because there wasn't a vote in the Senate, and many of the administration's proposals stalled. I mean, they just didn't move forward. There were a few that have moved forward. There's an insulin demo that's going to go into effect. States are going to have the right to move forward to do some importation. But in terms of policies that would really rein in drug prices, they just didn't move forward to the point where they got serious consideration.
Commissioner, from your vantage point, what do you see? Where do you see the roadblock existing?
Again, I think we've all sort of been hitting on it, and that is that I think the original market engagement of PBMs was useful. I think if you go back to their origin, that they were very useful. And I'm not suggesting that they can't once again be useful. But I think what's made it difficult, both in terms of regulation and as well as the politics, is because of the concentration of business that we are now down to so few that they carry a significant clout politically. And so I want to just offer, I know how hard Senator Grassley and Senator Wyden have worked on it, and I know how hard their staffs have worked on these issues. But you can really hear it from both sides. I mean, our president has spoken a couple of times about how mad the pharmaceutical companies must be at him because the reality is they have gotten so big, it is going to take a bipartisan effort to solve it. It cannot be done on one side or the other aisle. But I just view that at the state level, we've kind of run into the same issues that, you know, when Casey talks about the impact on competition, not recognizing that if you're down to 3 players and now 3 players are entangled with some insurance companies, I mean, you start to wonder, well, how is it that you possibly have competition left? And what is going to need to be done in order to restore competition? Because just more price requirements or, you know, transparency certainly would help. But it seems to me that so much of the design now is caught up in confidentiality, caught up in trade secrets, and caught up among trade secrets of companies that are really just down to a very small number of, quote, competitors. So the market system isn't working well, is what I would offer. And the politics are such that it's going to take a bipartisan effort. And it's going to have to be a strong bipartisan effort to get this resolved.
Anthony, it seems that, you know, when there is an issue like this that has on one side lots of deep pockets, which have strong interests, it seems like the role for an organization like AARP is to get those real life human being examples out there, because it makes it a whole lot harder to argue against it when you've got real people with real lives and real stories.
Yeah, you're absolutely right. And I think, look, I do a grassroots organizing training, and one of the things you look for is on issues is there's 2 types of things. Is the issue widely felt or is it deeply felt? And when there's a synergy between something that's both widely felt and deeply felt, it will pass. So I want to revisit the issue. This is going to pass. It's not going to be because it's going to be easy to do. There are forces even probably watching this call, certainly who will watch us afterwards, who will be opposed to what I'm saying and the notion that the prescription drug reform will pass Congress. I believe it. Actually, I agree with Commissioner. It's going to take a bipartisan work. But, you know, this is something, look, Senator Grassley still talks about this almost on a daily basis. He's not the only one. The House did pass a bill. That's an important thing to say too. But Randy, to your point in question, I mentioned the stories, and you know, you talked about our consumers asking for too much. No, I don't think anyone can make the argument. You've opened the door, so I'm going to read you just a few more stories from some of our Iowa State Fair participants. My 3-month retear was $1,800. I did not take it. There's a whole subsection. Again, an intern, I spent a month going through these, sorting through these. And it's hard to even sort through even the 253 best. What do I talk about? People are choosing between drugs and food to live. Our fixed income cannot afford meds and mortgage. But here's one of my favorites. 2 of them. I'll say prices are too high. Mexico, much cheaper. Mexico, $4, US 20. And this guy, this is one of my favorite. Simple, much more efficient with his words than I will ever be. Drug in 1964, $10. Today, $489. Why? It's also fortuitous. I hosted a SHIP call. Commissioner, I thank you. The SHIP stands for Senior Health Insurance Information Program. They do a wonderful job. I think it's one of the best in the country. They are people housed in the insurance commissioner's office that help people in Medicare sort through prescription drug issues on an individual basis. That's my plug for them, what they do is help individuals sort through this. But you hear stories that come out of people struggling, and even, yes, there's now, we can talk maybe, Randy, about, there is a, for 9 of our 28 plans here in Iowa for Medicare, there's a cap for insulin that would put a cap at, I believe it is $35, no more for a 30-day supply. That's 9 out of 38. So I think Casey talked about this, and the commissioner talked about some of the steps have been taken in Iowa and nationally to move forward, to make some things better. But I believe there will be a comprehensive bill, and it's going to be because, and I can say it because he's not on the ballot in part, but also it's accurate. He's one of the champions. And I do want to revisit this notion. For those of you that want to do a little follow-up, go back and watch the hearings that Senator Grassley held in 2019 from the CEOs. First, he brought in the people from the PBMs, and then he also brought in the CEOs of the drug manufacturers. And drug manufacturing is really key on this because it has to start with list prices. If you wanted to complain about the price of car, yes, you look at dealers, but you look at the list price. When you go look at a new iPhone, do you blame where you bought it at the store? You have to go and think about where the costs start with, and that is the list price. And by the way, I mentioned the thousands of people that shared their stories. There are real issues, especially with the supply chain, as Casey really did a great job articulating the pressures that are put upon pharmacists by PBMs. But not one person of these thousands of stories mentioned PBMs. It doesn't mean that it's not a real piece of it. In fact, I think the Commissioner and Casey both noted Senator Grassley's bill absolutely has PBM reform in it at our state level. In 2018, I know Commissioner talked about some of the challenges to the PBM reform bill that was passed, but PBM reform certainly putting that part of it, but you have to have real reform on list prices. I'm optimistic, Randy, because people are sharing their stories. And by the way, they're sharing their stories still throughout this COVID crisis. That's still happening, but I just want to finish. I mentioned the Senator Grassley's hearings with the CEOs, the drug companies. There was a lot of discussions, not surprisingly, it's, there's a blame gaming of look elsewhere, it's someone else's fault. Senator Grassley asked directly the CEOs, who finally showed up. It took a second round of meetings for them to show up. But he asked them, if we do all the PBM reforms that you ask, it was a very direct question. I will not spoil the answer. You have to look it up yourself. Will prices go down if we do all the PBM reforms? I'm not going to spoil the answer. Go back and look and see what the answer is for yourself. I bet you have a lot of guesses what they are. So yes, it is going to have to be bipartisan. I believe that will happen, and I can safely say that because Senator Grassley is one of the key, but also it's going to take Democrats too. I'd also bring up, since the commissioner brought up, I came to AARP in 2005, and it was actually 2 years. It was 2 years after prescription Part D was added to Medicare, but it was during implementation. Randy, I think you were around for that too. We worked with Republicans as an organization to get that passed. Being criticized, I still get criticized from people on the left for that. And one of the things that there's criticism at the time is the donut hole, valid criticism. Some of the other things, the extra payments made to different industry, valid. Well, guess what happened in 2009? Again, maybe not a perfect law, but the donut hole closed because of the ACA. So prescription drug, like so many pieces, you're never going to get everything at once, but we can get things that are meaningful, and I believe we will do that, not because of anything I do or say here, but because I know where voters are. And if you don't believe me, just tune in to our Senate debate tonight, or turn on your TV. You'll see the TV ads, and I can bet you're not going to go a day without seeing an ad that references prescription drug prices from both the Democrats and Republicans. Yeah. But ACA, I'll just say, if looking at revisiting that also reopens some of those doors, if you will, that prescription drugs are part of it.
So, Casey, what do you see a solution to all of this looking like?
Yeah. So first, Anthony, I think we could do both. Let's just do both. And then because Anthony and I think we've had this discussion before, and from the perspective of the association, we support lowering drug prices and helping consumers on both fronts. We obviously tend to focus on the role of the PBM more because they are who set our reimbursement rates and who are constantly squeezing those margins to try to siphon patients, whether it's to their own pharmacies that they own or to their mail order pharmacies. But certainly support looking at solutions to lower drug prices across the board. As far as solutions go, Randy, I think, as we've all alluded to, comprehensive reform at the federal level is a must if you're really going to get at attacking some of these problems. However, it's easier to pass legislation at the state level right now, and we're all aware of that. And I think part of that, and Anthony alluded to this, is that, you know, whether it's Pfizer or whether it's CVS Caremark, most of our districts in the state of Iowa don't have a presence that's felt from either of those manufacturers or those pharmacy benefit managers. And I tell this to our members all the time, to not always pay attention to some of those high profile issues that are in the news, because most of the time, I think a lot of our legislators are really trying to look out for their constituents. You might disagree with what those views are, but I think they genuinely want to do the right thing. And there's a lot of legislators who want to attack these problems on both sides of the aisle. So I'm more optimistic about passing legislation at the state level. A big part of that problem, at least when looking at PBMs, and that's what I know best, so I can speak on that, is exactly what Commissioner Ommen mentioned before as far as ERISA preemption at the federal level. All that being said, it's good timing because just last week, Rutledge v. PCMA, which is a case that was appealed out of Arkansas, like the commissioner mentioned, had oral arguments, and hopefully we'll have a decision here maybe sometime in the spring that could really affect our ability at the state level to possibly pass legislation or look back at some of our legislation on the books and see whether or not we can start effectively enforcing PBM regulations against those ERISA plans. So those commercial plans and your private employer and union sponsored plans, which is a large swath here in the state. So I'm more optimistic, like I said before, that we can find some solutions here at the state level. And Anthony can probably speak to some of the bills that have popped up as far as targeting the manufacturers. Here at the state level, there was, I just want to mention quickly, a bill, House File 2553, last year that passed the House 100-0, which you don't usually even see 100 legislators, I feel like, at the same time. So that we were very proud to see that number come out, but it targeted some of the practices I talked about before from PBM. So spread pricing, steering to PBM-owned pharmacies, anti-mandatory mail order, so forcing patients to utilize mail order pharmacies, all of those things that we think have a direct impact on reducing access for patients. It's harder with ERISA to look at more of the upstream consequences, and there's been some legislation that was fought pretty hard here in the state to look at changing the way that PBMs extort rebates from the manufacturers, which was fought pretty heavily. So I guess, Randy, that is a long answer to a short question that I think we can get stuff passed at the state level. I don't have much to do at the federal level, and Tricia said it very well as far as inching our way towards some comprehensive reform. But I will leave that in her hands, and I'll concentrate on passing state legislation.
Can I just throw in one thing? Because several people have talked about this being a bipartisan issue. And in our polling, we have sort of, I think, extraordinary results, because what we see is that Democrats, Republicans, and independents, by large majorities, want policymakers to do something about drug prices. The numbers are really big. It's like 90% Democrats, Republicans, and independents. And they want almost any policy. They want to give the secretary the authority to negotiate drug prices. They want to do something about inflation. They don't really understand these middlemen, you know, the idea of the pharmacy benefit managers, but there's almost no policy that you can mention that the public says, like, yes, do that. And they say that on a bipartisan basis. So I do think that is something that members of Congress know. They campaign on this. Both sides of the aisle campaign on, we're going to do something about drug prices. So in some ways, it takes organizations like AARP to keep their feet to the fire. And I think, you know, it's doable. It's just going to be tough because they're really good at opposing even simple changes, like let's have some transparency, right? A lot of states have tried to get transparency laws on the books, and they've been fought pretty aggressively. So it's definitely doable. It just takes a big
Tricia, if I just quickly add, Randy, if I might on that, because actually, Tricia, I didn't tell you this, but the Kaiser Family Foundation is some of the data sources I used actually in presentations last year. I think I'm looking at one of yours, to your point, last year. Now, again, it was pre-COVID, and it was a year ago, but lowering prescription drug costs was by far the top issue when it comes to what is your top health care priority. Next under that was ACA protections is 70 to 69, so it's close for people with pre-existing conditions, which everyone knows. Again, you can also see the ads around that, certainly in play, but prescription drugs knows that out, and it was certainly higher than if you get into some of the more partisan notions, repealing and replacing the ACA or implementing Medicare for all. By contrast, it's not even close when you look at just prescription drug costs being across the board issue. It really struck out. And again, not just because you're on the panel, Kaiser Family Foundation does some great real tracking that we still use. But I just do want to reemphasize it wasn't lost. Randy, maybe you want to build on that. Even during COVID, I will push back on this notion that, COVID has, for instance, at least derailed the impact for users and their costs. And, first of all, it's absolutely connected to avoiding being able to go to a hospital potentially if you're correctly taking your medications. Again, thanks to the pharmacists and others who help people stay on track and scrimp and scrape to figure out how to do that. But it's connected to this absolutely. And, and the costs have not gone away. In fact, the urgency to make sure people are still adequately using and properly and getting their prescription drugs are heightened. So, and again, on non-prescription drug calls, as someone who sees all the questions that comes in, we will get a multitude of prescription drug costs, even when we're talking about long-term care. Someone's going to bring it up. And so it's on the mind, and yes, AARP, we're proud to, help elevate those voices. But again, don't believe me, just turn on your TV and watch ads, what you'll see tonight and tomorrow and the next day.
So, Commissioner, if you had a crystal ball, is this a matter of simply getting through the election and getting into the new Congress and getting up and running then, or is it going to take more will than that?
So I learned a long time ago, I don't have a crystal ball.
You have plexiglass?
I got out of the election punditry a long time ago as well. But I guess I'm reassured by hearing the other panelists talk about this, because I can't think of anything really more important. I mean, don't get me wrong. There are a lot of issues out there for us on the healthcare front, but I really can't think of anything more important. It's frankly one of the issues that the Affordable Care Act really didn't address. I mean, and so it's out there with the concentration in the market. As I said, I can't think of anything more important. So I am willing to work. I can just assure you that Senator Grassley's office has been all over this. Hearing Anthony talk about that has made that eminently clear to those that are listening in. But we are willing at the insurance division to do anything that we can to lower a shoulder and help on this, because as you've already heard, this is probably the most important thing we face in terms of.
It wouldn't be a panel if there's not disagreement. Allow me to push back, Commissioner. Closing the donut hole was a big deal, and that was part of the ACA. You can say, is it far enough? No. Was Part D, when it's passed, far enough? No. You can say something that are meaningful and then also realize there's more steps need to be taken. So I'm optimistic, but just pointing out more needs to be done, and always building off laws. But it was absolutely a step forward. And again, if you see ACA repeal, that means by definition, absent legislation, the donut hole gets reopened. So it's actually magnified if that's one of the things not addressed. So I get you. I'll be waiting in my 16 years lobby for the first perfect law, but it's a law that did a lot of good. But I also think whatever happens next, both in prescription drugs and healthcare, I think you and I would agree that there's certainly a heightened need to show and have something be bipartisan.
Yeah. I'm not sure, Anthony, what you heard me say. What I was saying is that in terms of the ACA, it did not address this. This is another step that needs to be taken. Maybe I'm misunderstanding what you're saying there, but
closing the prescription drug donut holes, one of the pieces that the ACA did. So yeah, one piece, but a big deal for people that hit that donut hole.
Understood.
So, with the downer discussion this afternoon, of taking 35, drugs and the cost per month of all of that, it seems like there's kind of a sense of optimism of what's sort of over the horizon once we get past the election and get a COVID vaccine into people's shoulders. But I guess one of the questions I would go to Tricia with is, what are we apt to see once there is actual movement in both the House and the Senate and the White House on some sort of a reform plan? Are we going to see the insurance companies and the PBMs coming out of the woodworks with all sorts of lobbying money to fight tooth and nail?
Yeah, sure. The question is how much can be done in a year, and next year a lot needs to get done. This whole, with COVID, you kind of moved very quickly through, a vaccine will get approved and distributed and in everybody's shoulders. That's like a big deal, right? And that's an enormous task, and we still don't know about the economic fallout and how quickly it'll take for the economy to rebound. We're not done with COVID, and I don't think we'll be done anytime soon. So there is this issue of how much can be done by the Congress in any given year. Because I'm not saying they can't chew gum and tie their shoes at the same time, but there's a lot on the plate. Now, I think if there was a will to put prescription drugs at the top of the list next to COVID, we're keeping in mind that there's some ACA issues that may need to be dealt with by the Congress, depending on what the Supreme Court does. Yeah, I think it's possible. And what you would need to see is the House pass a bill again. It would probably look a lot like the last bill they passed, which is different from the Senate bill. The Senate needs to pass a bill. It didn't come to the Senate floor. So if the Senate majority doesn't change, I don't know that a bill would come through the Senate floor. I don't know. I mean, maybe it would, maybe it wouldn't. And, so it's possible, but let's just pretend it happens and there's a House bill, a Senate bill, and a willing White House. Yeah, if they were doing serious negotiations, I think you would be seeing ads on TV that would talk about how price controls will kill incentives for research and development, and people will die because they're not going to get the drugs that they need. I think it'll be an aggressive attack if the effort looks real. There goes my optimistic side, the sunny side that I had a little earlier.
I'll add there's some positive movements Casey mentioned this, to revisit the state and in Iowa. I mean, PBM bill that passed, there was actually a bill that didn't, COVID interrupted our session, but there was a insulin cap bill passed in the House here, as well as the actual drug industry transparency, but it also passed unanimously. I'm not sure if I was present, but both unanimous. So other states, Florida, there was a lot of hubbub of Florida passing an importation bill. I know one of the pieces, a lot of states, frankly, across the political spectrum have looked at pricing commissions or boards that look at this. So there are pieces, in other words, not just AARP, but states aren't waiting. I think you already heard that, to at least look at what they can do and where there's agreement. And I think whatever does or doesn't happen in Congress, I think you'll see, you know, whatever those bills look like. I think, I don't know if, again, Casey, the commissioner, agree that there's a real probability that some of those things that ultimately didn't go over the finish line last year will be revisited at the Iowa state level too. And the spirit of Iowa ideas, optimism, and frankly, consensus.
Commissioner, I will turn to you to help end this on a more positive note, since we've let the air out of everybody's balloons with the hand wringing. So are you an optimistic person, even if you don't have a crystal ball?
Yeah, I'm generally an optimistic person. So I not only have I given up political punditry, I've given up predicting the outcome of Supreme Court decisions. That Rutledge case, I mean, we've been watching that litigation very closely. The states have worked together. Anthony kind of mentioned the activity at the state level to try to find a path. And the states have worked together. I know our office was involved in some of the development of the law that Arkansas eventually passed. Iowa Attorney General Tom Miller has joined in that litigation as an amicus in support of Arkansas. But there's a lot that hangs on that case for us as states. And you know, trying to navigate around ERISA or through ERISA is not an easy task. It's been really a difficult challenge for us. But the optimism in me is that the Supreme Court's going to get it right. I mean, it's you can't really make any predictions based upon questioning. But if they don't get it right, then Congress has to get it right, because I think what we've learned over the years in terms of consumer protection is oftentimes it's not just the federal government or just the state government that needs to have engagement on this. I mean, we regulate pharmacists in our state, but a circumstance where neither us nor the Attorney General can regulate the markets that surround the pharmacist is nonsensical. And so I would just say the optimism is eventually I think we can win this, but we're going to have to really stay after it.
Well, I want to thank our panelists today. This has been a terrific opportunity for all of us to be able to tap into the wisdom of four very informed people. I want to thank our audience for joining today and our hosts at the Cedar Rapids Gazette. Thank you all for participating.
Thank you.
Thank you.
Thank you.